Good evening, all. Good evening, prominent speakers present here in this meeting. I request Jitesh to start the
recording in progress
and continue with this. Jitesh Shinde.
Yeah. So good evening, all. So it's an honor for me to introduce Dr. Mangal Parihar, sir. So to start with that, Dr. Sir has done his MBBS in June 1984, and he stood first in the University of Mumbai. Also, sir completed his MS Ortho at very first attempt in July 1988. With his overseas register post and the fellowship, sir has teaching experience of more than 25 years. And sir has present clinical appointments in various hospitals in Mumbai, such as Mangal Hospital, Chembur, Wockhardt Hospital, Fortis Hospital, and GMC and Sir JJ Group of Hospital, Mumbai as Honorable Orthopedic Surgeon. And sir is an Honorable Life Member of IOA, POSI, BOS, and AOAA. And sir has been invited as a faculty member as a single or in association with others for more than 100 courses. And sir have many publications done by them. So I request Dr. Mangal sir to take over the session.
Thank you. So today, what we are planning to do is to discuss neglected or late presenting fractures around the knee. So the program is that Dr. Pradip Nemade will speak on neglected intra-articular fractures around the knee, especially relating to the use of internal fixation. Dr. Divya Ahuja, my colleague, will speak on the role of external fixation for these similar kind of injuries. And I will speak on something slightly away from the knee exactly, that is periarticular fractures. And I want to try and bring up the sagittal plane, which is sometimes not well understood or not well realized. Pradip is known to everybody who does trauma. He's an associate prof at KEM Hospital and GS Medical College. Divya Ahuja, my colleague, has been working with me in the Ilizarov field reconstruction since the last many years. And we try and take an overall sort of approach in the sense that it's not that always internal fixation or always external fixation. You have to select horses for courses, as we say. And after the presentation and during the discussion, we will try and outline some of these areas where each of us thinks that, external fixation is very important or internal fixation is better. So without further ado, I will invite Pradip, Dr. Pradip Nemade, to share his screen and go ahead with his talk.
Thank you very much, sir, the entire Janssen team. So I'll be speaking about the role of internal fixation in malunions around the knee. So just share the screen.
Miten, are you there?
Yes, sir.
Yes, sir. Acha, okay, it's on now.
Okay.
Dr. Pradip had some.
Yeah.
Yes, sir, it's okay.
Okay. So, malunions around the knee, and by knee, I mean to say I'm going to focus mainly on the distal femur, because when it comes to the role of internal fixation, it is not a rule, but most of the distal femur malunions or non-unions are treated by the internal fixation. And on the tibial side, more often than not, we will try to go ahead with either external fixation or a combination of internal and external fixation. So majority of the cases in these presentations are based on the distal femur, and the reason for that we'll discuss during the talk. So we have different scenarios. We have fracture issues such as we can have malunion or null-union. We can have either a metaphyseal issues, or we can have an articular issue that can be partial articular or a complete articular. We can have bone loss that is at the level of articular cartilage or at the level of metaphysis. We can have open injury to begin with, which is complicated, so that can lead to infection, and that can be a further complicating issue to the patient's presentation. Other issues such as duration of the problem, previous surgical interventions that leads to some scarring, different that really obliterates the definitions of the bony fragments. So that can also create a lot of issues. Other issues such as the soft tissue, either soft tissue defect or soft tissue scarring. How is the skin, whether it is stretchable, stuck to underlying bone, and the quadriceps muscle status and patellofemoral mobility. So all these issues, if you take into consideration, each patient presents to you with a unique kind of scenario, in a unique kind of situation, and you need to sculpt your program in your treatment program around that particular situation. And so no two patients will be alike. Each patient needs a different kind of management. And the different difficulties that we are going to face in treating this malunion or kind of non-unions are the approach-related difficulties, such as there might be an approach already taken by the previous surgery, or maybe because of the bad skin condition, some approach might be precluded. So those difficulties can be there. We can have extensive fibrosis in and around the knee, either interarticular fibrosis or fibrosis around the quadriceps muscles. We can have length issues, shortening kind of thing. And sometimes we may not be able to visualize the original fracture lines because either they are inaccessible to your approach, or they are completely obliterated by the new bone formation. So all these difficulties again are there in treating these kinds of malunion of these fractures. Especially if you see the difference between femoral non-unions and a tibial femoral articular malunions and tibial articular malunions is that femoral articular surface can be exposed to you directly because the anterior part is visible in extension and the inferior part is visible in flexion. Whereas tibial articular surface, if you see, that is most of the time is covered by femur, and you cannot really open the tibia like we see the femoral surface end on. So that's again a major difference between treating a femoral malunion, articular malunions, and a tibial articular malunions. Now, a partial articular fracture can be a sagittal plane fracture or conal plane fracture. A sagittal plane malunion or a non-union can lead to either intra-articular step. It can lead to conal malalignment and subsequent arthritis. So if you see this patient now, this patient presented pretty late, almost at 8 weeks to 10 weeks time, and it is already into non-union. This patient is not going to unite like that. So this is the simplistic kind of the case, almost as like the regular case, just that there will be a little bit of fibrosis, so that you need to clear off and just fix it with multiple KYS, and the original fracture lines are pretty easily, it's very easy to demarcate the original fracture line if the patient presents this early. However, when the patient presents pretty late, that can be a little bit difficult. So coming to coronal fracture line, coronal fracture malunions, the issues are the range of motion restriction, which can be either in flexion or extension. Sometimes the fragment, if it is very small, can get resolved and can lead to instability. So if you see this fracture, now there is a gross restriction of flexion. That is because when these fractures malunite, they tend to shift posteriorly, and that increases the anteroposterior diameter of the femoral condyle, and the excursion for the adequate rollover of the tibia on this condyle, there not adequate excursion is there, and that's why they have decrease in the flexion. You can have again the patella also may not give that much excursion, and a bony step. Sometimes the fragment is so big that the tibia subluxate along with it posteriorly, and there's a bony step that can occur and that can prevent the further range of motion. Sometimes we can have range of motion restriction and extension. Generally, extension is full as only posterior condyles are involved, but may be associated with a diaphragm fragment, like in this case, or arthrosis, and that can lead to pain and restriction of extension as well. Sometimes, if the fragments are very small, especially the posterior fragment, that can undergo resorption, and it's because the major supply of this is by the superior medial genicular artery, and a fracture like that really makes it osteochondral fragment, and that can undergo resorption. So treatment options in these cases are depending on the functional status of the patient, activity level and demand of the patient, and skin and fracture combination. So we have multiple options such as redoing the recreating the fracture and fixation, or we can just leave it alone if the functional disability is not much. We can excise the fragment if it is very small, and in very difficult cases we can do orthoplasty. Of course, we are going to we can do just metaphyseal correction also, and we'll see that case also. I think Dr. Parihar will discuss that case also. So need not be always intra-articular osteotomy. We can do treat this fracture by extra-articular osteotomy as well. So intra-articular osteotomy is considered in young patients with less comminution, good skin condition, good bone condition. So there are a few case reports and on and off that are described that discusses these kinds of osteotomy. So what are the osteotomy consideration in this? If you see the distal fragment, or the posterior fragment, it just tilts posteriorly and it shifts proximally as well. So there is always a new bone formation that is associated with the malunion. So that is just not just osteotomy and sliding of the fragment. So we do need to take care of this new bone formation. And the hinge is shifted and tilted, so that uniplanar osteotomy or wedge correction may not be always possible. So what is really required is a 3D osteotomy. So in these cases, if you see whatever marked in the red is a new bone formation, so that needs to be wedge excised. Whatever diapunch fragment needs to be totally isolated and lifted up, and then the entire posterior condyle fragment needs to be tilted and shifted proximally to fix it. So this is a three-dimensional osteotomy that needed to be done. So to do this, we need to do a direct articular approach. We cannot approach it from the side. We need to approach it directly from the fracture surface. And these are not the cases for mini incision. We need to do proper medial parapatellar approach to expose the entire femoral condyle on face. And we need to estimate the bone overgrowth so that we can take adequate excision of those bone overgrowth, because if we don't remove, then the anatomy can never be recreated. Then there can be soft tissue restraint in relocation of the fragment. Laterally, there is a popliteus tendon and LCL attachment, and medially there is the capsular attachment and MCL attachment. So that needs to be taken into kept into mind while we are trying to mobilize these fragments. So if you see this patient, so she was a 16-year-old female. She had a Hosp fracture, and she was treated with K-wires. I don't have that X-ray, but she was treated with K-wires, which were later removed. But this fragment, if you see, is a very typical example where the posterior fragment is tilted posteriorly, shifted, and there is a dipunch fragment. And if you see CT scan again, look at the APU diameter of the lateral and the medial condyle, and it really increases a lot. And we know that this tibia is not going to roll over that posterior condyle, and that is the same thing that we see. She has really very small jog of motion. So again, here we take either we can take a midline incision, but since there was already an incision taken, so I just took the same incision, extended into this, so medial parapatellar incision. And then you expose the knee just like a medial parapatellar orthotomy. and try to see the entire fracture femoral condyle in front of your face. So as you try and dissect out the tissues, try to take out some fibrous tissue, and slowly your flexion will start to improve. Sometimes the cruciate ligament also are entangled in bony fragments, so you can just nibble off some of the fragment to the pituitary punches and just try to take out the excess bone. As when you remove the excess bone, you just depress that, so you see that the die punch fragment has been now elevated, and the defect has been created underneath that, and the wedge of that bone that has been excised, and the bone was closed. And then we apply a clamp and just close that bone and fix it with the screw, and that is at the end of the fixation. So more or less the articular congruity now is maintained, and on table she has got a very good range. So if you see the post-op X-rays, again, this need to be evaluated with the oblique X-rays to see the contour of the condyle, that there is no step. And we have done the CT scan also, and now we can see how beautifully the anteroposterior dimension of that condyle is now been restrained as compared to what it was pre-op. So that's how this three-dimensional osteotomy can be done for treatment of this kind of the coronal plane fractures. So similar case, now she presented little early, and the kind of deformity also was not much. She was a 25-year-old female, and again she had some not much of a deformity, but she was pretty young, so we decided to go ahead and do osteotomy. So this is how you see, just when you expose, we see all the fibrous tissue, and that is trying to breach that bone. But slowly you take the spine punches and try to take off that thing, and slowly you will be able to recreate the fracture site. You recreate the fracture site and then take out the excess bone, and you will be able to close the fracture, and then you can just fix it with the screws. And that's how her range of motion has improved, and she has got almost more than 110 degree range of motion. Sometimes this fragment can be really small. So these are the posterior fragments, and like that. So again, this has gone into non-union. So you go expose this fragment, drill that area, and then we can fix it from posterior to anterior, like that, in a deep flexion kind of a situation, because anterior to posterior screw will not be possible. She is a case with a unique kind of a situation where it's a bicondylar Hoofa fracture, and she was again not treated and got malunited in that position. So again, it's kind of a inferior base wedge kind of a malunion, and she has a very restricted range of motion. So we can see that how her fragments are shifted up and tilted, and again as the similar kind of this thing was taken medial parapatellar approach, and we try to expose this, and now we can see that two surgeons are working simultaneously to take off that bone. And we try to take off that bone and recreate the fracture line again. That was a fracture like that, and then everything was reduced and fixed again. However, while doing the osteotomy, our osteotome swayed a little bit, and we can see that sometimes complications like that do occur, because rather we should not do the breakage of the posterior hinge by osteotome. We should just keep on nibbling the bone till we get the thinnest bone possible. If you try to recreate the fracture site with osteotome, a complication like this can occur, as it has occurred in this case. And then there was little bit of valgus that has occurred in the fracture site. Though her articular cartilage was restored, she had got metaphyseal problem. So that's about the partial articular fracture. So if your total articular fracture, so we can have malunion, we can have non-union, we can have comminuted areas, fragments of the articular surface, and then we can have rotational in sagittal plane, or rotation in axial plane, or rotation in coronal plane, and we can have shifter as well. So look at this fracture now. She was a lady. She was actually waiting for total knee replacement when she got this fracture, and then it was fixed like that. and it is pretty common in these patients when they have a varus to begin with and kind of bored femur. Um, the fixation which was attempted has holded only the anterior part, and the rest of the condyles will not hold, and that fixation gave way just like that. So again, the treatment plan is similar. Now here we have to do a swashbuckler approach rather than medial parapatellar approach. So we take a swashbuckler approach. We again try to recreate the fracture site slowly. It takes some time, but we need to go slowly and just recreate the fracture site, and now and fix it from both sides like eye-strong kind of a fixation, medial and lateral, so as the articular surface is fairly okay with this now. And she went on to unite, and that is around 4 to 5 months follow-up. She is now around 1.5 months follow-up, and she's united and walking independently. So now with this, now she can, if it's better for her future TKR whenever she wants, it can be done a pretty simple way. This was a young female, a total articular fracture. Again, it was a compound injury to begin with, very beautifully managed initially with external fixator, the initial damage control orthopedic, and then later on fixation was planned. However, again, if you see in this fixation, the entire condyles and the shaft, they are not aligned in a lateral plane. In AP plane, they are fairly okay with rotation, but lateral plane, they are not managed. They are not pretty aligned. So tibia and femur axis, if you see, they are not in one line, and this fixation is not going to give, not going to last for long. And you can see that the Herbert screw that are used to fix that also starting to get loose. So the crux of this management is this patient is getting these condyles and the shaft orientation properly. So we went ahead. So that is her range of motion, 80-degree range of motion to almost full extension. So we went ahead, reduce this fracture, recreate the fracture line, remove all the implants, again recreated the fracture line, fix it. So there was kind of a small bone loss around the articular surface, but we could get the posterior condyle alignment to the shaft properly, and then that was fixed like that. So we have fixed with multiple screws. Anteroposterior screws were also passed to have a better hold into this fragment. And if you see now, the posterior condylar alignment to the shaft is somewhat restored, and that's how was post-op X-ray. That reflects immediately into the functional output, and the patient is now able to fully see it, and she's got full range of motion. Now, this case, though it's not kind of a neglected or malunion, but I included in this presentation for a peculiar reason, is to how to manage these small fragments. So this was a patient which has presented to us, and she had the previous tibial condyle fracture and the spine fracture, and she had this weird kind of comminution posteriorly. She had a very badly comminuted distal femur, a very weird kind of comminution posteriorly. So our team tried to fix it, however, and they got a very good reduction. But however, somewhere during the fixation, entire thing fell off, and the plan to abandon the surgery at that point was taken. Whatever fragment that could be fixed with K-wires that were fixed, because surgical time was going too much. So the team decided to fix whatever is possible, and then try to do it at later date. So at a later date, what we do is try to fix it with multiple K-wires now, because these are just shell of the bone is remaining, and put a big spacer. And this plate, we applied cement even on the K-wires to kind of lock these K-wires and make it kind of a locking plate kind of a thing. And at the second stage, we went away, removed everything. Now what has happened that all the distal fragment has basically we have converted a C3 fracture into a kind of a metaphyseal non-union, because by this time the articular surface is united, and now we are just dealing with the metaphyseal bone defect. So we removed everything, took lot of bone graft, fix it again. We used so that was a bone defect. So that was the thing. Screws. and few screws were passed out not in a non-locking fashion. That was the fibula, and then those screws were again locked with the cement, like that. Those screws are again. So we had get even though we cannot get a locking screw in that fragment, we can pass small screws and lock them with cement in a salvage kind of situation, and then the fibula to have medial support, and then she went on to unite. She got roughly 80-degree range of motion. She got roughly 80-degree of range of motion. So sometimes we can have predominantly metaphyseal malunion. So this case like this, so we have a fracture that is articular surface is fairly aligned, though there is some kind of a trochlear malunion there, but that is not troubling the patient much. What is problematic to the patient is that the patient is in varus and is in extension. So this is the case which I borrowed from Dr. Parihar sir. And then it was again treated by metaphyseal osteotomy and fixed with internal fixation. And then he went. So thus the alignment was restored to a great degree, and then it went on to unite. Another case. Now this was the case where there was a multiple implant inside, and sometimes it becomes very difficult to basically access the anatomy with those many implants in situ. So we can just remove the implant and evaluate, get a CT scan done and evaluate this fracture. And again, we can see that there is after removing the implant, the main problem is mainly the varus, and that one again corrected and fixed like that. So sometimes we can have a major metaphyseal problem, and we can just tackle the metaphyseal problem. Small articular problem can be left just like that. So take-home message is that we need to do a proper evaluation, know the function of the patient. Patient's expectation is extremely important, because all these cases may not be able to take the knee to the pre-trauma level. But what we need to do is to salvage the situation and make them much better than what they are today. Prevent the arthritis or delay the arthritis. Key issues in present condition need to be seen in patients' clinical radiological evaluation, and we try to address the major issues and not to run around minor issues. Osteotomies are feasible. Intra-articular osteotomies also are feasible to a large extent. Meticulous recreation of fracture lines when needed can be done by using fine instruments, and stable fixation goes without saying. Thank you.
Thank you. Thank you, Pradip. So I think all the attendees, you have a chat box or a question and answer box over there. So please feel free to put in your questions into that. We will look at those and answer them. So it's just at the bottom of your screen, the Zoom window. So I think this was a great exposition and showing the fact that just because there is an intra-articular fracture which has not been dealt with for a while, you shouldn't give up on these patients. These can be recreated. Even what is the longest time interval that you have dealt with, Pradip?
I think the bicondylar Hopa was 2 years. I think. Yeah.
So when there are big blocks like that, 2 years, you can reasonably easily get them into position. Grossly comminuted, maybe that time will be a little shorter, but there's no reason to give up on these kind of fractures. Of course, primarily we try and fix them, but even there, you saw the example that Pradip showed that you're having trouble fixing up the multiply fractured distal segment, and you kind of give up in the sense that, okay, we are now not able to do it. We are going to come back again. And that is something that should always be kept in mind. We go in with a complete plan to complete it. But occasionally, if there is a problem, we can always bail out in the sense that, okay, we are not going to do this today. We will come back another day. The second thing is asking for help. Now with so much of social media, WhatsApp and stuff like that, there's never a problem asking for help. And some of these situations may not be everybody's cup of tea, but there are enough people, I guess, now who can deal with these kind of complicated injuries. So that is another thing that we should, keep in mind when we are dealing with this. Now, we'll finish Divya's talk first, and then Pradip will come back to, when to do internal, when to do external kind of thing. Right?
Yes, sir.
So, Divya, you want to go ahead, and folks who are attending, please do ask questions. There are, there may be many questions in your mind which may not be obvious to me. So please feel free to ask. And that's the whole reason for this. Divya, you can share your screen and start, please.
One second, sir.
Can we take a question, sir?
One question already, okay. While Divya is starting up.
So we are very happy to announce that we have Dr. Ram Prabhu also with us.
Yes.
And
Stamp of approval, this is. If Dr. Ram Prabhu is listening, that's a stamp of approval. So, Pradip, he's asking, is there a possibility of algorithm to predict the outcome of complex malunion post-op?
I don't think so right now, because the variable factors are too many right now. So that's where the judgment of the surgeon comes into picture. So we do have left alone few of the fractures, predicting that this may not have a very good outcome, and later on just do a replacement later on whenever possible. But I think more or less whenever we have a young patient, bony blocks are big and we can fix them. Major problem of the patient is because of the alignment problem. Those will definitely have very good outcome. Patients who are in their very poor bone stock and very small fragment, again, those are going to have poor outcome. So I don't think so. There is a very fixed algorithm. Lot of is to be attributed to the surgeon's judgment and surgeon-patient's interaction, I think so.
My rationale for that would be that I would like to reconstruct them with the idea that even if you saw many of Pradip's X-rays of the articular surface, they didn't look what is known as perfect. But it's very likely that they will carry on for a long time as long as the alignment is okay. That's number one. Number two, even if that knee goes bad in the future, you have set it up for a good primary knee replacement. So from that point of view, I think it is always worthwhile to reconstruct. And for somebody who doesn't have, maybe more than 20, 30 degrees of movement, even if they get 90 degrees, it may not be the same as what they would have got with a primary surgery. But even if they get 90 degrees, that's a good advantage. But your point is taken that there is no particular algorithm which will predict that, okay, this one is going to do well. Let's put it another way, Pradip. How many of the patients that you remember that you have done of these have not performed or have not achieved a reasonably painless functional outcome?
Almost all of them are improved. One patient which is not included was not included in this thing because it was an infection case. It didn't unite even after 2 or 3 surgeries, and she had a because the previous surgery which was done, they had taken off the entire quadricep and the patella was completely basically bare,
right.
Just embedding into the pool of fibrous tissue. And the patient didn't get any range. I think he was stiff in extension. He remains stiff in extension.
Yeah. So the large majority, have done well and are continuing to do well. I'm sure that, we will not claim that they are going to do well for their lifetime. Maybe they will get onset of arthritis earlier than they would have otherwise. But even, you delay that arthroplasty for a longish while, I think that's a win. Okay. So we'll go ahead with Divya's talk. And meanwhile, if there are more questions on Pradip's talk also, please put them into the question box. Go on, Divya.
Good evening, everyone. Now we'll discuss a bit about the role of external fixators in the mal and non-united fractures around the knee. So basically, I want to talk about two things here. The role of external fixator, which is indispensable in certain situations like infection, the soft tissue problems, if there are small osteoporotic fragments, if there's a bone loss, and what we call as mover and shaker, where we want to use the fixator as a tool to achieve a goal, like a stiff non-union, where you just want to realign, distract, realign, and hold it in position and get it healed, or use it as a reduction tool for correcting the deformity, and then or distract the non-union followed by internal fixation. So showing a few cases of each case example here. So this lady, 48-year-old lady, had an HTO and presents with the pain and swelling in the right knee and leg. So difficulty in walking, had this HTO about 6 months back, and developed an incision site infection within 2 weeks. The surgeon did go ahead with debridement, added antibiotic stimulant, put her on IV antibiotics, but unfortunately things didn't settle down. And this is at the time of that debridement. So once the incision was opened, there was all granulation everywhere, and the osteotomy gap was seen there with that blue arrow pointing to the allograft which was put in. The green arrows are the showing the stimulant pellets. As time went by, the hinge at the lateral condyle fractured, pointed by the red arrow. The implant started loosening, developed non-union at the osteotomy. The blue arrow is showing the loosening in the proximal fragment. So this is a very, very small fragment now, and compromised skin, non-union. There's intra-articular extension of the osteotomy, very small fragment. The initial issue of varus and pain is still not handled. So we go ahead and did a PET scan. The infections all around the plate. Take out the implant and added compression at that lateral condyle fracture. Put in wires and then cancellous screws on that. This is the picture after the debridement. This is the foot end to the left. The white arrow is the yellow arrow is the shelf in between. The blue arrow is showing where the proximal screws were, and the white arrow is where the osteotomy gap or the non-union is. So after debridement, thorough lavage and all, we have added the stimulant inside and held this osteotomy open with the tricortical strut grafts with the green arrow. The cancellous screws are holding the lateral condyle. And then on top of that, we add the Ilizarov fixator as a neutralizing fixator, which is now maintaining the alignment and holding. So essentially, the non-union is being managed by the graft and is being held by the tricortical graft. The fixator is then working as a neutralizer. And the blue arrows there show the stimulant pellets. Post-op X-rays, alignment is good. And she goes on to healing well at 4 months. That's a gate at the time of stress test. X-rays showing good healing. That's at the fixator removal. We also added the graft in the void there for the screws. This is at 1 year follow-up. Doing pretty well. So at this point now, this mild virus remains. HK is 177, but she's asymptomatic right now. So we'll see if at all she becomes symptomatic later. She can again have another tibial osteotomy later, because the MPTA is still 87. So she still has a scope. So going on to the next one with the compromise in the skin and the small fragment. This 56-year-old gentleman, chronic inflammatory demyelinating polyneuropathy, had a roadside accident with and superficial abrasions on the skin, multiple scaldings, and presence around 3 weeks post-injury with this kind of X-ray. Now the fragments are, this is an intra-articular distal femur with just probably like an eggshell of that fragment which is remaining. So now what to do in such a small fragment? Internal fixation, hardly going to be any hold, very osteoporotic fragments because of those steroid therapy he has had. The skin is issue. So the plan was then, let's wait for the abrasion to heal, maintain it in a slab, and then relook and see if the CT scan gives us the size of the fragments and any internal fixation with some kind of flap is possible. The backup would be a Ilizarov fixator. So underlying tissue was clean after the scab removal, so not a full thickness loss. The fragments are too small in the CT scan. Hardly any of the screws of any internal fixations going to have a hold. So we went ahead with the Ilizarov fixation for this patient. And the fixator was a knee spanning fixator. Just 3 wires into that fragment and holding the shaft with the additional sham screws, and the tibia is being held. Started walking next day, 10 weeks, started showing good amount of healing on that shell there. And CT scan confirmed bridging callus. And at 14 weeks, we have done a stress test and good amount of weight bearing is there. So the fixator is removed, put him into a cast, then followed by a brace. Because of his osteomalacia and all, he just developed another stress fracture in the proximal tibia, and then developed some varus and recalvatum at that. He's been moving around with a brace since then, but the femur has united really well there. Now, using the fixator as a reduction tool, as we call this, this is a 7 months presentation. This 45-year-old male had compound injury, and then initially was treated with a plate which failed. Then he was put in a Ilizarov fixator which also failed, and then he ended up with this really oblique non-union, very proximal non-union. So again, internal fixation will need to mobilize the fragment quite a lot. So we use the fixator here as a tool as a reduction tool. So the 6-axis comes very handy in this. We have from this picture on the left to the right, this is how we have brought down the fragment and then held it in place with the fixator. So this is what we do. The fixator is put on and use the 6-axis to do the movement stage by stage. The first stage is just a distraction in the same position, and then you angulate, and then you translate and dock it together. So that is at the end of the first stage. The red fragment is yellow. Yellow is where it is at present, and red is where it will be at the end of the program. So that is at this. That's the second stage. Now, after it has been distracted, we translate it forward and bring it under the proximal fragment. So that's the end of the second stage. AP and lateral. Come back under the proximal fragment. Any fine tuning, if required, for the frontal alignment is done. And with that, then you can just compress it together. Now, especially with these oblique fracture lines or oblique non-unions, to achieve compression is really important. Otherwise, it always keeps shearing off and with the axial loading. And then, so we try and get one end into the other and jam it together, telescoping into the other one. So for this, the 6-axis device is really, really handy. So that's the position at 2 months. Once everything's done, we convert the 6-axis to straight rods and allow weight bearing. At 4 months, he was walking really well, but the X-rays was not showing good signs of healing. So we put on the 6-axis device again on the fixator and then further compressed it and allowed him to walk. Then 8 months, again, healing not really convincing, but he was walking really well. And then we did a stress test, which changed his gait. So that meant that there were some areas of which were not yet healed. So we did a CT scan and then bone grafted the areas which were deficient. And after bone grafting, then he went on to heal well. And the fixator was removed. So another example where we use the fixator as a reduction tool, and then you can convert it into internal fixation. So some tips to share about that. 31-year-old lady who had a fracture around 14 years back, and then this was treated just by a couple of screws, and then she continued walking on that. She was limping, but she never had pain and never went back to have an X-ray. And now, since 2 weeks, she was finding it difficult to walk and presented with this kind of an X-ray. Now, this shows the intra-articular non-union of that proximal tibia. That shaft and the lateral condyle are together, and it is riding high. The medial condyle is with the femur and is dipping down into varus, and there's a recavatum as well. So what we did was we put on the fixator. Now, if you were to treat it directly as with an internal fixation, you would need to really dissect it quite a lot. How would you mobilize that fragment which is riding so high? So the approach is use the fixator to distract and regain length. Also, that allows to mobilize that non-union so that you can manipulate those fragments well and then go on and do a fixation, internal fixation and grafting. So that was the stage 1. Put the fixator in situ after the screws were removed. Use the 6-axis to distract that out. So there was about 30 millimeters of overriding. red fragment is where it will be at the end of the distraction. That's at the end of the distraction. Now we can see some semblance of proximal tibia at that level and maintain it for 10 days to 2 weeks in that distracted position, and then go ahead for the second stage. So the fixator is then removed and open midline approach. The patellar tendon was with the medial plateau. Remove all the fibrosis, freshen it. Now it's very easily, those fragments is just being held up apart to show that gap in there with the right angle. Basically, no real force is required because all the work has been done by the fixator of mobilizing that fragment. Freshening it, holding it with the clamps, and adding some interfragmentary screws and a locking plate on top. So with the locking plates now, conversion to an internal fixation is really possible, provided all the soft tissue cover is good enough. So that's the post-op X-ray, well aligned, and no porous is seen. They added Genex at about 2.5 months in that lateral void which was there. And then she went on to have good amount of healing. There is a little bit of lysis happening around at that screw, which has then been removed. So that's her at the end of 2 years. No complaints, walking really well, back to her full activities. So there the fixator helped us to tackle that non-union. So the learning points here, basically at some areas, the fixator is indispensable. There's no question about it. Infection, when there's soft tissue issues, small fragments. How do we achieve a stable fixation within those small fragments is by getting those crossing wires, getting them tensioned, add drop wires as required. The I-beam construct of those 4 rods on the rings really helps in adding to the fixation. A ring can be added to span a joint whenever required so that additional stability can be achieved. You can use the fixator as a reduction tool nowadays with the 6-axis device. All these complex closed maneuvers are possible. Moving that fragment, distracting it, translating, and then jamming it together gives good stability and reconstruction possibilities. And complex stage composite reconstructions can also be done. There the tip is then to keep the fixation away from the incisions and the site of where the implant is going to be. You manipulate the fragments with the fixator and then go on to add your internal fixation, convert it. Thank you.
Thank you, Divya. So, Pradip.
Yes, sir.
What your comments and first questions, any and comments? That distal femur which he showed, which was just an eggshell left.
Yes, sir.
So using an external fixation, it is very likely that the knee range is going to get fired. Okay, but with that kind of bone, what do you think? Some form of internal fixation you could have tried. You would have tried.
So in tibia.
No, that distal femur, jo ekdam eggshell tha wo.
Sir, means in femur external fixation means I'm not very keen on putting wires and pins in the femur. It definitely leads to very cumbersome for the patient to think. At the same time, we can somehow manage it with the combination of cement and plate screws. So I think fixator is always at the back end option. If this cannot be done, then there's no option but to use the fixator.
Okay.
But my take is like, if it is possible by somehow doing some adjustment, and if we can maintain it with the plate, if infection is not there, then for femur would like to use plate.
No, that's what I'm saying. That's why in that, generally I will try and use a plate for a femur. But in that particular thing, osteoporotic bone, there is a bad scab on the front of the knee.
Yes, sir.
And the patient is, with multiple medical comorbidities.
Yes.
So there, to me, safety is more important.
Yes.
So that he has a leg to walk on.
Yes, sir.
Rather than try to fix it. That's the sort of way I was looking at that one.
Yes.
So that was mainly, and also that tibial patient.
Tibial, yes, sir.
Would you have done something differently?
No, sir. Fixator is always better in for the tibia, because as I said, in tibia it's very difficult to visualize the soft tissue again. It's like in femur, we can, with a single exposure, we can expose the entire femur all around. Tibia does not give that much luxury to us. Internal and recreating the fracture sites and managing the metaphysics in tibia is far more difficult with this, and getting a length with fixator, as Divya showed, and a fixator does most of the job, and many a times we just may have to tweak around a little bit later on if at all internal fixation is warranted, but most of them it may not be warranted at all.
So yeah, I think so. That is one of the points that Divya made. That, okay, where there is infection, risks of internal fixation, where there is length discrepancy, and the soft tissues. So soft tissues in the tibia are much less forgiving, I think, compared to the femur, where you've got a reasonably good soft tissue envelope. And that is probably one of the main things where we decide between femur and, between internal and external fixation. So I agree with, meaning I also believe in the same thing, that yes, when we use a fixator on the distal femur, you can get quite a lot of stiffness. But sometimes that is a choice that is made to balance against the risks of breakdown and things like that. So patient actually, if you remember the video, patient is pretty comfortable with the fixator. That's not a problem. But later on, yes, you can get, you do get some amount of stiffness. We have ways which are described for the Ilizarov, where the way that you put in the wire and things like that, which can reduce the stiffness. But in that distal fracture, probably not. Okay, so I will extend now to the metaphyseal region, and then right now there's no questions, burning questions waiting. So that means I'll go ahead with my talk and right. So specifically, I'm talking about metaphyseal area, neglected or malunited, meaning either presenting late or malunited. And I want to try and make a specific point in terms of the sagittal plane, because that is something that many of us don't look at absolutely correctly. And I'm going to try and share some tips which I use to correct these. So whenever you have a malunion or a displacement, whether it's varus, valgus, these are things which are clearly visible. When you look at the patient from the front, You can notice that varus valgus. Procurvatum, recurvatum tends to be a little bit hidden clinically because your knee is moving in the plane of the deformity. And especially on the X-ray, if you are not conversant with all the sort of angles and looking at it carefully, you may miss it. When it's a malunion like this of the diaphysis, it's very easy to visualize because both arms of the non-union, proximal and distal, they tend to sort of amplify that deformity. And this kind of deformity is not difficult to correct with external or internal fixation. Even with external fixation, you put in fixation perpendicular to the proximal fragment, you put in fixation proximal to the perpendicular to the distal fragment. And even before you do the osteotomy, as long as your pins are well aligned, the moment you do the osteotomy and correct it, you will get a good alignment on the AP and lateral. So that's not very difficult. But what about something like this? Here, where is this guy? Is obviously he's united at the back. He's obviously malunited here. But otherwise, should you be correcting this here? Should you be correcting this here? Should you be correcting this here? That tends to be a little bit of a problem. Even then, you can see the varus pretty clearly, but you may not visualize the recurvatum of the distal fragment if your X-rays are not good and if you are not paying attention. So here is a chap with a obvious varus on the full length X-ray, but on the lateral, if your X-ray is not proper, you can't really make out much, One sec. So on the lateral, you can't make out too much because that X-ray is not done properly. On the AP X-ray and the lateral X-ray, these numbers are well known to all of us. Everybody knows now, I think, about the lateral distal femoral angle, LDFA, and the MPTA. I'm only talking about these because right now we're talking about the knee. But equally important is to recognize the difference between flexion deformity or hyperextension deformity at the knee versus procurvatum and recurvatum in a particular fragment. So if you see Dror Paley's book, there is a line of the epiphyseal scar, which is in the lateral view considered to be the joint line of the distal femur. And in relation to the joint line, if you draw the mid-axial line of the distal femur, because the femur is bored, so we are only looking at the distal femur, you have something known as the posterior distal femoral angle, which is normally 83. If you get an epiphyseal arrest at the back, and this keeps growing, for example, or this can also happen in a malunion, you may get a flexion of the distal fragment of the femur. Similarly, if you are not careful in terms of how you are fixing it, you can get a hyperextension or an extension or recurvatum of the distal fragment of the femur also. Now, why do you not recognize this? Is for two reasons. As I said, one is your positioning is not correct. So unless you have a dead lateral view, you can't make out what is the relationship of the distal femur to the shaft or the proximal tibia to the shaft. And when you get a dead lateral view of this, then you can clearly recognize that there is a hyperextension. One second. There is a hyperextension of this distal fragment. And if you look closely, you will find that there is also an intra-articular fracture there. This is the anterior part of the condyle and this is the posterior part of the condyle. So this you can make out just on the X-ray. You don't even need a CT. Yes, to further delineate it, I would always do a CT, but the recognition can be done definitely on X-ray. So if you position this properly with the condyles superimposed, posteriorly, and then know what is the relationship of the condyle to the shaft, what we call the PDFA, or what is the relationship of the proximal end of the tibia to the shaft, then you will know when there is a deformity. So in the tibia, this is called the PPTA, posterior, proximal posterior tibial angle, or arthroplasty guys call it slope. Normally, this is 80 degrees to the long axis of the tibia. So when it is reduced, then you have a procurvatum. When it is increased, you have a recurvatum. And this, for example, if you see this X-ray, this is a true hyperextension at the knee, because you can see that the PDFA looks to be okay. This is less than 90. This one is also less than 90. So most of this deformity is happening in the knee itself and not in the bone. Some people measure it through the mid shaft. Some people measure it through the anterior cortex. Some people measure it through the posterior cortex. Effectively, all three are the same. So clinically, how do these guys present? When there is a significant sagittal plane deformity, they will present with pain also due to overload, but often they complain of a feeling of instability, and this is misread as a ligament issue. When it's mainly a coronal plane deformity, they will complain of generally pain due to overload. So this is the same case that Pradip showed you. We did this together. So obviously you can see that there is a varus, and that varus is kind of centered somewhere here, and there is a recurvatum. Now, the amount of recurvatum in the distal femur relative to the shaft of the femur is pretty large. But if you look at the femur relative to the tibia, the hyperextension is not that much. And the reason is, if you just focus on this portion, this patient over time has developed to a certain extent a flexion deformity in the knee. So that's like a compensation for that hyperextension. So ultimately, when we are going to correct this, we are only going to correct it to get the tibia well aligned to the femur. That's the amount of flexion he has. And if you look at that lateral view, what I was telling you about the PDFA, if this is the joint line, 80 degrees, that's where this line is going. And the blue line is the proximal axis. You can see that the condyles are mismatched. They are not absolutely parallel, and that's because of a fracture in one of the condyles, which has malunited slightly. So in these kind of cases, we've done 3D models and stuff like that. Now, going by our principles of osteotomy, the cora is here, and it's at a similar place in the lateral view also. The blue line is an 81-degree line extended from the joint line, and this is the red line is the mid-axial line. So here, what I'm doing is I'm extending the axis of the tibia. I'm holding the leg in the maximum extension, and I've put in a wire in the distal fragment, which is perpendicular to the axis of the tibia. That is effectively the axis of the limb. And then put in another wire proximally, which is perpendicular to the shaft. So basically what that is doing is that is telling me how much recurvatum is there. The next is to put in an implant, because he had varus also, to put in an implant which is parallel to the knee joint. Okay, so the screws, or just like a blade plate, the screws of this locking plate should go parallel to the joint, which you can. So that is not absolutely perfect. So we've changed that, and now you can see that, relatively speaking, in terms of the distal fragment, the plate, anterior and posterior edge, are, relatively speaking, well aligned to the distal fragment. They are not so well aligned to the proximal because this is going back. And on the AP, you can see the joint line, and these screws are perpendicular to that. So we fixed the plate distally first, keeping it such that this is an extension, and this is actually this picture. I don't know whether I have another picture which shows it. No, there is this tibia was held in extension, and this plate is in line with the tibia in maximum extension, right? And you can see the angle between these two wires. That's the amount of recurvatum that needs to be corrected, seen better over here. And you try and keep them as parallel as possible so that you don't induce any, in the axial view, so that you don't induce any rotation. Once that is there, the osteotomy is done at the cora. You can see the two wires over here, and the plate is fixed. In this, you can see that the plate is much more posterior. So now I've got the plate well aligned on the AP view because the screws are parallel to the joint, and now I've got it aligned on the lateral view as well. And we use this, what I call a Sasta Navigation. It's nothing but a protractor which is printed onto a large OHP sheet with a zoom in. And then when we do the SIAM picture, we have a wire cautery cord which is held over the center of the femur and the center of the knee, center of the head of the femur and center of the knee. And then you can actually read off that, okay, this is now, you can see about 80 degrees, this in relation to the shaft. And that's at the end of correction. You can see the two wires are parallel to each other. When you look at it axially, they are in the same rotation as they were. This patient, as I told you, had a little bit of a mismatch. This is a 3D print of the distal end of the femur as it should be. We had made a template for that in case we decided to correct it. But since this was reasonably small and he had a good range of motion, we decided to leave it alone. This is what Pradip was talking about, that small things you can tend to leave alone. So that's his X-ray at the end of correction. He went on to heal without any trouble. Now, here is this patient with, if you draw the long axis, you will see that this is significant varus. He had a malunited compression sort of on the medial side. But if you look at the lateral, you will notice compared to the opposite side, there is a certain amount of recurvatum. So if you only correct the varus, he may not be completely satisfied because that recurvatum is also going to trouble him. And in fact, clinically, he came with the issue of recurvatum. So here, it's a simple HTO kind of surgery. The only thing is, once you do the varus correction, normally we say for an HTO, you keep the spreader in the back so that you don't get a slope change. In this case, what we do is you keep the spreader on the front so that your slope has also changed. Now, sometimes it becomes difficult as to what to concentrate on, the varus or the recurvatum. Some of that is you have to play it by ear. But the basic funda is, if you do this kind of osteotomy, especially with internal fixation, you keep it anterior, you will change the slope. And that's the fixation. And that's his correction. So now you can see that the varus is largely corrected. He's come back to his native varus, but more importantly, compared to his recurvatum, he now has got a normal slope of the tibia. So in terms of execution of the femoral correction, I think generally I would prefer to use some sort of a fixed angle device, either a locking plate or a blade plate. Very important is a dead lateral on the C-arm. You need to externally rotate the limb a little bit to get them parallel. And then put in wires perpendicular to the appropriate segment. Wires should be in the proper rotation. And the plate long axis should be aligned to the tibia in the lateral view whenever you have a recurvatum or a procurvatum, as the case may be. And the first screws on the AP should be aligned to the joint line. In terms of the tibial correction, again, you can use wires to delineate your deformity, do the osteotomy as described, and putting in a spreader in this particular situation anteriorly increases the slope. If you have a situation where the slope, anterior slope is increased, you may need to do the reverse or take out a wedge. And this use of the Sasta Navigation, as I said, is something that is pretty useful and important. So that is my take on managing malunited or late presenting metaphyseal deformities. Of course, with the Ilizarov, any kind of non-union, any kind of deformity can be corrected gradually. But wherever feasible, and once you get an understanding of what the deformity is, it becomes that much more easy to correct it with internal fixation, which becomes simpler for the patient, also becomes simpler for the surgeon, because taking care of an Ilizarov patient in terms of long follow-up, etc., does tend to become an issue, where the patient is not from town or from out of town and things like that. So I think we are reaching our designated end time. Any additional things that you want to add, Pradip?
No, sir.
You had dinner or no? Not had. That's why no, sir. Divya, anything you want to add?
No.
Okay. So I think there's no question from the attendees.
I think,
So
sir.
Yeah, tell me.
The case, I think we had used a small plate to begin with to correct it, because to put a long plate in a flex position, it may not be possible.
Yeah.
I think that case we first use a small plate, drill all the holes, and then I think we replace with a longer plate. That's the trick I think
Yes.
that we are using.
Yeah. So what I use a smaller plate, pre-drill all the holes, so that now after you've completed the osteotomy, the holes are ready to accept screws. You correct the deformity and then slide your longer plate inside. Because otherwise that the long arm of the plate, proximal end of the plate, becomes difficult to slide in. Or you can, of course, you can dissect and raise the whole muscle, but that's generally not a good idea. You need a template for those screws. So what you pointed out is, yes, you use a smaller plate and pre-drill the holes, and then once the deformity is corrected, you change to a longer plate. Right. So I think with that, we are at the end. I will hand over back to the J&J people, Jitesh and Mr. Shelar.
Thank you so much for your kind presentation and elaborative presentation. If some of the participants are still there online, so if I can unmute them, they can have a direct interactions with you.
Yeah,
So
sure. If anyone has questions, we are happy to answer them.
Yeah, all those who are interested, please raise your hand. I will unmute you so that you can ask questions directly and interact.
There is one question. Bracing protocol. Just unmute Vijay Kumar Lakshman Rao. Vijay Kumar Lakshman Rao Sadulwar. You can ask your question, Dr. Vijay Kumar. Bracing protocol in relation to what?
Sir, can you unmute yourself?
I think Miten, you have to unmute the doctor.
You will have to unmute it. Yes, Dr. Vijay Kumar.
Sir, good evening, sir. I mean to say, in post-operative phase, what kind of bracing should be suggested for the patient? Will it be a graded protocol? For example, what kind of flexion movement, what kind of range of motion should be permitted?
Actually, in most situations, in the Ilizarov, I know that I don't take off the fixator till it is healed.
Yes.
And rarely will I use a brace, because I think the Ilizarov in that sense is the most secure and convenient brace, because it's holding things. If you have good internal fixation, then also I don't think you need a brace, as long as the patient is compliant. If the patient is compliant in terms of touchdown weight bearing till you see healing, then I don't think the brace per se is required. See, the brace does nothing against weight bearing problem. The brace only protects against varus valgus and maybe to a certain extent procurvatum, recurvatum. But even procurvatum, recurvatum, because the knee moves in that direction, is not so much of a problem. So if your fixation is sound, then I would say, really speaking, bracing is not per se required. If your fixation is sound and it is the whole system is stable. For example, you have a good bone-to-bone contact.
Yes, sir.
Then the system is stable. One of the cases which Pradip showed, where there was a shell distally, and then he put in cement.
Yeah.
Now, once he put in cement, the idea was, one, to create a space where bone graft can go in later. And the second is to create a stable situation. Right, Pradip? You want to add something to that?
Absolutely, sir. Yes.
So, you also don't use bracing, no?
No, sir. Absolutely no braces.
So the one patient which, like Divya showed, where the gentleman with severe osteoporosis, etc., where we had used a brace, that kind of patient, maybe I would use a brace, where it's more to protect them from, if they have poor muscle tone and things like that, not per se the fracture.
Oh, right. Okay, sir. Thank you, sir.
You're welcome. Anyone else has a question? No. Sure. And of course, later on also, if somebody gets questions, you can always
definitely have questions.
Email us, me, Pradip, Divya. We'll be happy to answer and share. Okay, Mr. Shelar, I will leave it to you to wind up the proceedings. Thank you very much for your invitation.
Thanks a lot to you.
Sir, thank you so much. Shelar sir. So thank you so much, Dr. Mangal Parihar sir, Dr. Divyajyoti sir, Dr. Pradip sir, for such an interesting session. And Doctor, it will definitely add to the knowledge. Also, I'd like to thanks to all the attendees doctors for their valuable time. And even I would like to thanks my J&J colleagues who have invited all the academic class of doctors. And thanks to Miten for setting up administrative and technical support. So on that note, I am ending this. I'm saying the end of the sessions. So once again, thank you so much for all the doctors and good night.
Thank you. Bye-bye.
Thank you.
Good night.
Recording stopped.